Good evening, everyone. Myself, Dr. P.U. Amit Uttam Chandani, MD Homeopath, specialized in PCOS and infertility cases. I have 8 years of experience in my clinical practice. I specially deal with PCOS cases and infertility cases. So, this seminar is dedicated for those people who keep messaging me via email, on Messenger, on Instagram, and keep asking me, PU ma'am, what is the remedy for left ovarian cyst? Dr. PU, what is the remedy for right complex ovarian cyst? And I'm shocked. As in homeopathy, we don't have a fit formula. So, do not understand me to have given remedies for PCOS. We cannot lay down remedies for diseases. The whole constitution must be most carefully examined. So before learning constitution, let's learn what is PCOS and how can we deal with PCOS cases. So let's start. Let's remember our master, Dr. Samuel Hahnemann, and start with the webinar. So I've published a book named PCOS and Homeopathy. It's by Europe publication. Indian version will be soon available till December 2020 by BGen Publishers. So this book is available in Europe publication house in 2 languages, in English and next is Portuguese. Indian version will be coming soon. Also, I have written Portrait Materia Medica book during my MD days. So let's start with the current hot topic, polycystic ovarian syndrome. First, let us learn about the basic, what is PCOS, its physiology, pathophysiology, its manifestations, and how can we deal with it. So polycystic ovarian syndrome is a complex endocrine disorder characterized both by reproductive and metabolic disturbance and is the most common cause globally of ovarian infertility. Now see, first it is said that it is a complex endocrine disorder. It is not simple endocrine disorder, it is complex endocrine disorder, which is characterized by reproductive and metabolic disturbance. Now what is endocrine? Endocrinology leads with the hormones. Wherever there is disturbance in hormonal level, that goes under endocrine disorder. What is metabolic disturbance? Metabolism leads with the utility of amino acids and proteins used in our daily life. So polycystic ovarian syndrome is a complex endocrine disorder, hormones, in which reproductive and metabolic disturbance also we can see. And it is the most common cause globally of ovarian infertility. Let's see the background information on polycystic ovarian syndrome. PCOS appears to be a common endocrine disorder of women of reproductive age. It is characterized by chronic anovulation and hyperandrogenism and can be clinically expressed with hirsutism, acne, or androgen-dependent alopecia. So what are the manifestations of PCOS? That is chronic anovulation. In ovulation study or follicular study, when you see the report, you cannot see the proper ovulation. Hyperandrogenism. Now, what is hyperandrogenism? The androgens level in female are increased, and so they developed androgenic alopecia. You can see the baldness in PCOS cases. You can see the hair growth on face, chin, that is hirsutism. You can see acne. You can see acanthosis nigricans, that is the pigmentation on the neck. You can see in PCOS cases. All these are clinical manifestations. Types of PCOS. First is hyperandrogenism, where you find normal cycle but polycystic ovaries in ultrasound. Now, a patient can come with the normal cycle, but in ultrasound, in USG, in sonography report, you can see polycystic ovaries. That is termed as hyperandrogenism. Next is normal androgens with oligoanovulation, normal ultrasound. Now, patient with oligoanovulation, many times there is anovulation. It's not like that anovulation may be in 1 or 2 months. In many months, if you repeat the sonography report, ovulation report, you can see an ovulation. But the androgens are normal. That means she's not having baldness, no facial hair and all, but with normal ultrasound. Uterus and ovary sizes are normal, no any other symptoms, but she's not having ovulation. She's not ovulating. Third type is hyperandrogenism, oligoanovulation with normal ultrasound. So third type is USG report is normal of uterus and both ovaries are normal in size, but there is no ovulation. Plus she's having baldness or she's having facial hair, etc. Fourth is hyperandrogenism, oligoanovulation, and polycystic ovaries in ultrasound. Here, the most complicated cases which we see in our clinic, that is from fourth type. Patient comes with hyperandrogenism, that is facial hair, she's having baldness, she's having pigmentation on the skin with both the ovaries shows cyst, and also she's not ovulating. Common age of onset is adolescence. Common type of diagnosis is second to fourth decade of life. Some symptoms may appear starting at menarche. So many scientists tried to explain the pathophysiology of PCOS and many studies were made. Let's see the history. History of discovery of polycystic ovarian syndrome. Steen and Levendel are regarded to have been the first investigators of polycystic ovary syndrome. Also, PCOS is called as Steen and Levendel syndrome. In 1721, an Italian scientist described a married, infertile woman with shiny ovaries with a white surface and the size of pigeon eggs. So, in Italy in 1721, a married woman who was infertile had shiny ovaries, which had white surface. In 1844, sclerosistic changes in ovary were described. In 1921, class description of a beard woman with diabetes mellitus. So nowadays you can see the patient with hirsutism who can develop beard. So that was discovered in 1921 with the complication of diabetic mellitus. In 1935, Steen and Levendel described the features of 7 hirsute amenorrheic women. In 1935, amenorrhea was noticed, that is missed periods. Paper on 75 women who underwent bilateral wedge resections, nearly 90% of whom began to have spontaneous menstrual cycles and 60% of those seeking fertility conceived. So later on, a paper on 75 women was given who went bilateral wedge resection, which is also called as an ovarian puncture, where 90% of the women began to have spontaneous menstrual cycle, whereas 65% those seeking fertility conceived. Normally called as ovarian puncture, which is the treatment given by modern medicine. Next, in 1962, laparotomy and wedge biopsy became the mainstay of both diagnosis and treatment. See here, they do the ovarian puncture, also laparotomy. The next diagnostic milestone occurred in the late 1960s and early 1970s with derangement in hypothalamic pituitary axis. So this is the hypothalamus, this is the pituitary gland. Endocrinology criteria were used for the diagnosis such as elevated LH and FSH ratio. So as we know, the normal menstrual cycle, the normal physiology under menstrual cycle is hypothalamus stimulates pituitary gland. This is the anterior lobe, this is the posterior lobe. Okay, GnRH hormone secreted from hypothalamus stimulates the pituitary gland. Anterior pituitary gland in turn gives LH and FSH, which stimulates ovaries. Ovaries secrete estrogen and progesterone, and the ovulation happens. So in modern medicine, hypothalamus handles everything. But as per the homeopathy, emotions, mind, very important. Mind stimulates the hypothalamus. So nowadays you can see PCOS in good quantity cases because mind is the major role. So as per the homeopathic view, mind controls the hypothalamus, and in turn hypothalamus controls the pituitary gland again stimulates the ovaries. So all funda is here. Next, pelvic ultrasound in 1970s and 1980s. First abdominal sonography and later vaginal sonography complicated the diagnosis. Later, 1970, 1980, the vaginal sonography and abdominal sonography came in existence, but that too complicated the diagnosis. In 1990, NIH criteria established for PCOS. In 2003, Escher, Rotterdam, Netherlands, consensus definition of PCOS, which now included the possibility of using polycystic ovaries as part of the diagnosis. In 2006, task force appointed by the Androgen Access Society. Conclusion was thus, it was not until the early 1990s at a National Institute of Health sponsored conference on PCOS that formal diagnostic criteria were proposed and afterwards largely utilized. So, as per my research, as per my conclusion, it is now accepted that PCOS is multifactorial. Many factors are responsible. We can't say that it is only hereditary. I have founded many cases where there is no any PCOS history in family, but patient is suffering from PCOS. So we can say it is multifactorial, partly genetic. Of course, genes may be present, that may be in silent phase, but not only this factor is responsible. Many factors are there. So partly genetic, susceptibility is more important, environmental factors are more important. However, number of candidate genes have been postulated. Next step, which I have gone through many papers, many literature, insulin resistance, very important in PCOS cases. I'm giving you one of my secret. Insulin resistance has been postulated, has been noted consistently among many women with PCOS, especially in those with hyperandrogenism, but it is not included in any of the diagnostic criteria. So you have a trio of PCOS, insulin resistance, and sex hormone imbalances. So whenever you get a PCOS case, just check her insulin level, fasting serum insulin level. In 50 to 60% of cases, the insulin is high. So let's have a look on female reproductive system. The female reproductive system is one of the most vital parts of the human reproductive process. Although a man is needed to reproduce, it is the woman who incubates the developing fetus and delivers the child into the world. These are some basics. The embryonic origin of germ cells. Females are born with a large number of potential ova, female sex cells, also called as egg cells. However, it isn't until after the onset of puberty, typically around the age 12, that these cells are mature enough to sustain life. So after the age of 12 or at the age of puberty, the primordial germ cells of ovary gets activated and the ovulation begins. The cells ripen on a regular basis, but only one is released each month until a woman reaches menopause. Menopause commonly begins between the age of 45 and 55. So, not the both ovaries are activated in the same month. If in this month right ovary is activated and right ovary gives the ovulation, the left ovary is passive. And next month, the left ovary will be activated and do ovulation, and the right ovary will be silent. So, alternate month the ovary gets activated. So ovaries are the primary female sex organs that produce the female gamete ovum. So this is the ovary. This is the fallopian tube, fimbriae section. It also produces several female steroid hormone, estrogen and progesterone. Ovaries produces several female steroid hormone, estrogen and progesterone. The ovaries are located in the lower abdomen. Each ovary is about 2 to 4 centimeter in length. These are connected to the pelvic wall and uterus by ligament. Each ovary is covered by thin epithelium, which enclose ovarian stroma. Now, ovarian stroma has two zones, a peripheral, this is the ovary, a peripheral cortex, and the inner medulla. At the peripheral cortex, follicles are present, and in medulla, that is in the mid, blood vessels and ovarian ligaments are present. So this is the structure of ovary, you can see. This is the primary follicle. This is the secondary follicle. These are the primary follicles. You can see primordial follicles which are present since birth. These primordial follicles get activated at the puberty. So this is the ovarian ligament. Ovulation occurs. This is the corpus luteum. When a graphene follicle or a tertiary follicle or a mature follicle bursts, it gives ova, and the remaining portion is called as corpus luteum. Developing corpus luteum. This is the ovulated ovum. Transverse section of ovaries. Let's learn about it. Developing follicles in different stages. Primary follicle develops into the graphene follicle with mature ovum. One matures around 14:30 of menstrual cycle and ruptures to release the oocyte to ovulation. Clinically, theoretically, they say 14 day. Clinically, it may be 12 day, it may be 16 day, it may be 20, 30. I have seen such cases where late ovulation happens at the age, at the 23rd day, 24th day. That is normal. So after release, follicle filled with blood clot and then yellow cells called corpus luteum. This corpus luteum secretes progesterone. So oviducts, uterus and vagina are accessory ducts. See. So this is the transverse section of ovary. You have blood vessels, you have primary follicle, primordial follicle. This is the primary follicle. These are the developing follicles. One of the follicle develops. This is the mature follicle. This mature follicle or graphene follicle ruptures and the ovum is liberated. And the remaining portion is called as corpus luteum, which secretes progesterone. Studies have given a general understanding behind the pathophysiology of PCOS. In a patient with PCOS, the primary defects are seen with two perspectives in the body. First is insulin resistance. Second is relatively imbalance in LH and FSH level. So always please check insulin, fasting insulin level of each and every PCOS case. So let's study what is this insulin resistance. If I'm repeating the same, there must be any importance of this insulin resistance. A person with PCOS may have insulin resistance. This means the cells within your body fail to respond to insulin hormone to take up glucose for the use of energy. Because glucose is not used up for energy, it results in storage of glucose resulting in weight gain. So this is the cell. The insulin receptor are vanished, right? And glucose is not used. So it is fluctuating in blood and forming the weight gain. Ultimately, the excess insulin within the body will cause the ovaries to increase production on androgen. This can lead to an ovulation. So what happens? The insulin within the body will cause the ovary to increase the production on androgen. That can lead to an ovulation. Furthermore, the two main pituitary hormone, LH and FSH, orchestrate. Normally, they orchestrate. Major changes in the body are essential for reproduction. So this is the luteinizing hormone. This is the follicle stimulating hormone secreted by anterior pituitary gland. LH and FSH to be in precise balance required to avoid complications. So this is the normal menstruation cycle where FSH and LH are in good ratio to maintain the menstruation. In PCOS, there is increase in LH. Normally, there is increase in FSH and LH is low. But in PCOS cases, there is increase in LH than FSH, which produces excess of androgen substrates that elevate testosterone level, which are associated with excess body facial hair. So why there is alopecia or why there is excess facial hair? Because of excess of androgens. Why there is excess of androgen? Because there is increase in LH. This increase in LH, what it does, it elevates this testosterone levels. And when there is increase in testosterone level, you get facial hair and hirsutism. Furthermore, when there is decreased level of FSH, the ovaries are not stimulated for maturation of egg and eventually there is no ovulation. This is the reason why women with PCOS have difficulty in conceiving and experience irregular menstruation cycle. So whenever there is decrease in FSH, if there is increase in LH and decrease in FSH, there is no ovulation. And that is one of the reason for irregular menstrual cycle and anovulation. So decrease in FSH gives no stimulation for maturation of egg, and there is no release of ECG. So clinical manifestations, we have amenorrhea, that is missed periods, which is because of increased androgen. You have hirsutism because of increased androgen. There is infertility because of cystic ovaries. This is the normal ovary, this is cyst in the ovary. There is obesity, too much of adipose tissue, too much of estrone. As we have seen, the sugar level, the glucose in the blood gets on circulating, and that forms the obesity. Also, which is associated with type 2 diabetic mellitus because of obesity. Increased risk of endometrium carcinoma may be there because of high circulating estrone levels. Insulin resistance has been noted consistently among many women with PCOS, especially in those with hyperandrogenism, but it is not included in any of the diagnostic criteria. Till now, in diagnostic criteria, insulin resistance has not been mentioned. So this is the diagnostic criteria of PCOS. NIH 1990 must include chronic anovulation, clinical and or biochemical signs of hyperandrogenism. In Rotterdam 2003, two of the three following must be present: either oligoanovulation or clinical and or biochemical signs of hyperandrogenism, or either polycystic ovaries on USG. Androgen Access Society 2006 must include ovarian dysfunction or oligoanovulation, polycystic ovaries on USG, androgen excess, hirsutism, hyperandrogeninum. This was the diagnostic criteria, but they have not mentioned about insulin resistance. So let's discuss about PCOS scenario in India. There are few studies conducted in India, studies done in South India and Maharashtra. Prevalence of PCOS by Rotterdam's criteria were reported as 9.13% and 22.5%. So in South India, you have 9.30%, and in Maharashtra, you have 22.5%. And it is increasing. It is not decreasing. It is increasing. References this link. So with this prevalence of PCOS, many hormonal therapy are being used for bringing the ovulatory phase back in the menstrual stages. In such therapy, side effects are involved with various secondary complications. In this way, homeopathy in such cases has shown miraculous results, which have brought the ovulatory phase in regulation with the females for the conception. These results are based on the evidence of ultrasonography scanning and the hormonal assay. So homeopathy, the science of nanomedicine with philosophy of holistic healing, is currently being explained as evidence-based medicine. Homeopathy in such cases has shown miraculous results which have brought the ovulatory phase in regulation with the females for the conception. These results are based on the evidence of ultrasonography scanning and the hormonal assay. So I have done research on PCOS cases, and so the book is published. Homeopathic case taking is an essence of understanding individual in diagnosing his personality and sensation for the prescription of similum. So it is said that, well, homeopathic case taking is the half cure. You should be perfect in case taking. So let's discuss one case. We will have a series of PCOS cases henceforth. Today, let's discuss one case. This was a case at my clinic, at my Pune's clinic. Female case, Mrs. Kashish of 28 years, housewife by occupation, complained of pain in abdomen since 6 months. The location was right side and the pain described by her was aching type. Aggravation modalities are very important. Menses during aggravation and after exertion, amelioration by hot application. Pain in right shoulder since 3 months. So she was complaining pain in right shoulder since few months, which was aching pain, aggravation by physical exertion, amelioration by ointment. Her menstrual history. So I took the case not in my format. Patient was going on speaking and I was recording the symptom. So after these two complaints, she started with her menstrual history. I did not interrupt her because patient's flow is more important. So she explained about her menstrual history: menarche, 13 years, interval 30 days, good flow for 3 to 4 days, clots are present, and pain in abdomen right side during menses. So she has pain in abdomen during menses. So past history, I inquired history of hepatitis, family history, father expired by heart attack, maternal side, mother is suffering from recurrent UTI, and also she had hypertension and diabetic history in her family. Personal history was nothing much specific: desire sweets +1, aversion not specific, thirst was good. Elimination, urine satisfactory, stool she complained occasionally constipated and unrefreshing, gases tension, perspiration was not much noted, that was normal on forehead. Thermally hot, sleep disturbed due to pain sometimes, and it was unrefreshing. Dreams of routine, fights with everyone. Constitution, she was average build and weight was 58 kg. Mind, very, very important. On inquiring about her mind state, she had visited my clinic with her husband. So anger on contradiction, anger at slightest things, feels crying if anything is not according to her. She said, I feel better by appreciation. I feel that I'm not loved. Also, she is obstinate. On observation, she was dominating on husband, treating him as she's boss. Language was like, Aryan Ture. Tu. She was behaving very rough and very dominating with her husband. That was an observation symptom. On examination, per abdominal examination, when I checked her, there was a tenderness present in right side of abdomen. Investigations were done, which shows right ovarian cyst. So here is the investigation. You can see complexed right ovarian cyst. The right ovarian cyst is 22 into 21 mm. I don't know why they have written tiny. It's not a tiny, it's a good complex cyst. So left ovary is okay. Right ovary is showing well-defined round to oval complex tiny cyst, not tiny, complex cyst measuring 22 into 21 mm, which is a big size. You know what is complex cyst? You have types of cyst: simple cyst, complex cyst, endometriosis. Complex cyst. Complex ovarian cyst contains solid material or blood. You have three forms: dermoid cysts, cystadenomas, endometriomas. Dermoid cysts are made up of cells you had since before you were born. Your body uses these cells to produce dermal tissue, so they may contain fat, skin, hair, or even teeth. Cystadenomas contain ovarian tissue with fluid or mucus. Endometriomas form when cells from your uterine lining grow inside of your uterus, in or on your ovaries. So she had complex cyst. So working off the case, any guesses about the remedy? So working up the case, I selected haughtiness as the theme, and also right affection. Right ovary was affected, and thermal hot. So these were the rubrics taken: mind, anger, trifle sad, mind egotism, mind haughty, mind weeping, abdomen pain, menses during heat amelioration, female genitalia, ovaries affected, female genitalia, pain, ovaries right, female genitalia, tumors, ovary, cyst, right side. Location is more important, modality is important, general side right. See, location, modality is covered, and mind is covered. Constitutional approach, purely constitutional approach. So final prescription was given as palladium. Palladium was selected on the totality, not because here it is first, but I compared palladium, lycopodium, and platinum. So palladium 30 single dose and water potency. I use water potency. I don't use dry form. Palladium 30 single dose in water potency was given. Follow-up: pain in abdomen slightly decreased, fresh feeling, pain in abdomen during menses. Again, she had pain on abdomen during menses after a month. Bleeding was profuse, sleep was disturbed. So again, I repeated palladium 30 single dose. Next, patient came disappointed as pain in abdomen as it is during menses. So 30 was not working. Remedy was right. She was feeling a bit better, but again the case relapsed. So we cannot change the remedy. So I shifted to higher potency, a bit moderate potency, we can say, not higher potency, moderate potency. Palladium 200 single dose. Follow-up continued with repetition of palladium 200. She was responding very good to palladium 200. After a year, USG abdomen shows normal ovary. So you can see the report just after treatment. Right ovary measures this much, left ovary measures this much. In right ovary, in previous report, you had 21 into 22 of complex cyst. Complex cyst is not easy to crack. Simple cyst is easy to crack. In complex cyst, you have many complications. The pain is terrible. So after investigations, after 1 year of treatment, right ovary is completely normal by single remedy palladium. Just 2 potencies were used. So let's see why I have selected palladium. I preferably refer source books. Boric, let's see about boric, palladium, and ovarian remedy. See, we haven't gone through this, na? Palladium and ovarian remedy. The first sentence in boric about palladium is given as an ovarian remedy. Produces the symptom complex of chronic ophoritis, useful, but the parenchyma of the gland is not totally destroyed. See, the parenchyma is not totally destroyed. But also on mind and skin. Motor weakness, averse to exercise. Let's see about mind. Weeping mood, low of approbation, that is appreciation. Pride, easily offended, inclined to use violent language, keeps up brightly when in company, much exhaust afterwards, and pains aggravated. Materia Medica by Clark. Clark is next source book, which I use. Palladium. Female sexual organs, pain and weakness as the uterus was sinking down. Every motion was especially painful. She could not stand well. Heaviness like a weight in pelvis, bearing down pain. Right ovary swollen. See, in Clark 2 it is given as right ovary swollen. So to pressure with bearing down pain. In the region of right ovary, drawing down and forward, amelioration by rubbing. Pain in right ovary, urgency to urinate, but scanty emission and sensation of weight and bearing down in pelvis. So as per the Clark 2, it is given that it is the right ovarian remedy. Everything is given about the ovary and uterus. Conclusion: palladium is one of the main remedies that we must think when we see huge tumors developing in the sexual organ of the female, especially huge tumors in the ovary. So palladium, one of the remedy for huge tumors. Not necessary that it is used for complex ovarian cyst. It can be used for endometriosis. It can be used for simple ovarian remedy. Again, I repeat, do not understand me to have given remedies for PCOS here. We cannot lay down remedies for diseases. The whole constitution must be most carefully examined. So why we haven't prescribed platina? Why we have prescribed palladium? Platina, the first impression when you meet a platina is her haughtiness. She treats other dismissively as if they are not worth her time. In fact, in clinic, I have so many platina patients who dominate on me. They are very dominating and very haughty personality. Her pride is accompanied by the feeling of ignored or abandoned by other. She's sensitive to rejection. She cannot bear the rejection. When a loved one leaves her, she's devastated. She's possessive about her relationship or about her loved one. She's very sensitive and excitable and tends to keep to herself. The sexual desire is intense in platina than any other remedy. She's ashamed to seek help for the sudden sexual impulses. The superiority complex is denoted in the delusion as well. Delusion of being a great person, delusion of grandiereness. Platina can be described as delusion of grandeur. That means she feels that I'm a great person. But in palladium, the theme is that she's not appreciated. I'm not loved. I'm not appreciated. But the haughtiness is there. And in platina, the haughtiness is there. But along with haughtiness, there is a delusion. I am great. Delusion of grandeur. Palladium has a strong need for appreciation from others, as we had seen in our patient. She was not loved. I'm not loved. I'm not appreciated. Platina displays superiority in her behavior, how important she is, but palladium hides this. She will never show the haughtiness. All her complaints began when someone has embarrassed her and wounded her pride. She wants to be flattered, imagines people ignore her and are better in the company. They are quite timid, lack self confidence. They can be quite egoistic, although they do not show it so directly. So Platina is the direct lady. Palladium is not direct. She shows indirectly everything. Platina and palladium both have a sphere of action on female reproductive system, giving rise to symptoms like suppressed menses, uterine prolapse, tumors, etc. So we can think platina and palladium as the complementary remedies for PCOS and female remedies, we can say. So that's it. This was the PCOS series 1. We will keep and continue discussing different cases. I will share as many as cases I have dealt with. Okay, chalo. Let's meet in next week defining some other case with clinical approach. Take care.